Hello, everyone, and Happy New Year. My name is Magdalena Decor, and I'm Chief Executive of FH Europe. And today's webinar is a very special one. Although it's part of the FH Europe Network annual meeting, which actually took place in November, and this particular webinar had been rescheduled twice, I am sure everyone joining us will appreciate and agree that the reason for this has been absolutely wonderful. And with a sense of great pleasure and achievement, I wish to welcome Action FCS with their brilliant chair to our network of patient organizations advocating and supporting people and families living with inherited lipid conditions. Action FCS, by joining, marks our 30th member organization. And with the arrival of this particular organization, we're finally able to strengthen our knowledge, support, and outreach in order to support jointly the FCS community. And it is with Jill's help that we have tonight such an incredible panel who will be addressing the topic together. And so please put your digital hands together and give a round of applause to Jill and all the panelists, or simply in the chat, post a welcome note and wish everyone a great webinar. Without further ado, I hand over to Jill, who will also be today's moderator and speaker. Thank you so much, Jill, and welcome.
So hello, everyone, and thanks to Magda for the introduction. I'm Chair of Action FCS, and we're delighted to be the new members of the FH European Patients Network and to be collaborating with FH Europe on this webinar. The topic of the webinar is Understanding FCS, and I'm very pleased to be joined by a fantastic panel of speakers representing patient and carer perspectives, as well as the perspective of researchers and clinicians who will see patients like us every day. Together with Jane joining us from the UK, we will share our personal stories, which we trust will help put the research and some of this inherited and rare lipid condition into context. More about the condition, genetics and management in the later part of the webinar, brought to you by Dr. Charlotte Dawson from the UK, Professor Rob Hegele from Canada, and Professor Alberico Catapano from Italy. We hope that at the end of this webinar, you will feel confident and empowered to better understand FCS. Those of you joining us for the first time, this webinar is the last one out of our 4 webinars under the umbrella of FH Europe Ambassadors Training. Now, FH Europe is a network of patients' organizations across wider Europe. There are 30 organizations in the network. As a community, we're committed to advocating for and supporting people living with inherited dyslipidemias like FH, HoFH, elevated Lp(a), and FCS. This session is aimed at raising awareness and increasing health literacy amongst our patient community internationally, lay public, as well as developing patient ambassadors. Now, we would love to know more about our audience. So please write in the chat who you are and where you're joining us from and what you hope to learn today. While you do that, I'd like to share some housekeeping rules. This webinar is being recorded and will be available on demand on FH Europe's YouTube channel, where you can also watch it with subtitles in your local language. It will also be on the Action FCS website. It's also streamed on Facebook. And if you have any questions, do not hesitate to post them in the Q&A section or on Facebook stream. We will try to answer as many as we can live in the same Q&A section. Please avoid any specific questions related to anyone's personal health records or treatments. So I'd like to kick off the official part of this webinar with my introduction to Action FCS and my personal story as an FCS patient. Thank you. So Action FCS is a patient-led charity based in the UK that aims to educate and raise awareness of FCS to support people affected by the condition and advocate for new medicines. We do all this by running an annual FCS Awareness Day, holding patient information sessions and producing materials and information that can be found on our website. We have a dedicated Facebook group for those affected by the condition and we have represented the patient voice at the European Medicine Agency and at NICE, the UK Medicines Reimbursement Agency. This event will definitely take the raise awareness and educate box. And I hope that if you have FCS or know someone who does, or you're a medical or other professional who works with someone with FCS, that you will direct them to our website and encourage them to join our Facebook group. As you'll already know, patients are recommended to eat less than 20 grams of fat. We're also recommended to avoid sugar and drink no alcohol. Many patients find they need to eat less than 10 grams of fat to avoid abdominal pain. This means fat from any source, so fat from oil and also from the foods from which the oils are derived, like nuts, seeds, coconuts, and olives. One medium avocado, for instance, contains about 22 grams of fat. It means fat from meat, from dairy products, and from egg yolks. The only exception is a medically prescribed fat called MCT oil. However, not everyone can tolerate this, and it can be difficult to cook with. Many patients do use prescribed MCT oil, and it is good for children to help them increase their calorific intake. But please beware, the MCT oil in whole food shops is not suitable for patients with FCS. All of us are recommended to avoid sugar, but this is essential as some of us also have diabetes. For some, drinking no alcohol is also problematic. Even with medication that may be available, a severely restricted diet is required, and this is never simple. In fact, it is severely restricting and very difficult. People are diagnosed at different ages, some as babies and some well into their 40s. Those diagnosed later in life often have their symptoms minimized or are blamed for drinking excess alcohol if they end up in hospital. Later diagnosis can mean that they already have sustained a great deal of damage to their pancreas, can also make it harder to adapt to the dietary restrictions. Patients come from different educational backgrounds and have different income levels, often affected by their FCS, which in turn affects what food they can afford. They come from different cultural backgrounds in which food can play a greater or lesser role, and live in very different environments, major cities with wide range of shops, or small towns or villages with restricted choice. Patients experience different levels of understanding and support from friends and family. They've been given different information about medicines they can have, and have different access to hospital or a doctor who's at least heard of the condition, let alone understands it, and different amounts of support from medical professionals in managing both the physical and especially the psychological aspects of living with this very rare and invisible condition. Added to all this, the condition requires the patient to be self-managing, and many feel guilt and/or are blamed when they're unwell. I was diagnosed at 2 and grew up knowing I couldn't eat fat. However, this has not stopped me from having all of the symptoms of FCS I mentioned, symptoms of FCS. I've often felt on the outside looking in, and everyone else seemingly eating and drinking without a care in the world, while for me, every meal was either a source of stress or guilt or both. Living under the threat of pancreatitis and the relentlessness of managing a severely restricted diet in a world that literally doesn't cater for me is very draining. And I've had recurring periods of depression throughout my life when everything has felt too much. I am, however, lucky enough to have married someone who's a fantastic cook and who spends time devising and cooking meals that I can enjoy. He also eats the same food as me, so keeps his standards high. We live in the centre of London with access to many different supermarkets and local shops that sell interesting foods from different cultures. We spend a lot of time looking out for things I may be able to eat, and I now have a good idea of which supermarkets offer the lowest fat versions of the various foods I enjoy, buying one thing from here and another from there. The basics of what I eat are very limited. Most meals feature either chicken or turkey breasts with all skin and visible fat removed, or very low-fat fish, white fish like cod. Everything is prepared without the addition of any fat. These basics can be cooked and seasoned in many ways and eaten with various suitable carbohydrates. I also eat plenty of vegetables, salad and fruits. Eating out, however, is a nightmare. I rarely do it, and only if I can find a sushi restaurant that offers something I can eat. However, if I need to eat out and sushi is not a possibility, I usually take my own food and get permission to eat it while whoever I am with buys food off the menu. I have very little spontaneity in my life. My first thought when planning or responding to an invitation is, what will I eat? This often means I exclude myself because accommodating my dietary needs will just be too difficult or too stressful. When I do venture somewhere where I have no control over the catering, I usually liaise directly with whoever is providing the food, and it takes a lot of emails to organise something suitable for me. However, this doesn't always work, and I found myself in situations where the chef has added just a little bit of oil to make my meal taste better, or I'm given a big plate of green salad and nothing else. Our holidays are always self-catered, and we check that we have access to a large supermarket. When eating with friends, we usually host. I trust only a very few people to feed me without having to get involved in menu planning. So I hope I've given you some insight into how hard it is to manage this condition. And even with all these factors in place, there are still aspects of my FCS which are out of my control. So now I'd like to hand over to Charlotte to explain to us from the medical perspective what FCS is. And thank you, Charlotte.
Thank you very much, Jill. I'm just going to share my slides. Can everyone see my slides? Okay, so thank you very much, Jill, for that wonderful start to the seminar. I'm going to talk to you a little bit more about what FCS is from a healthcare professional's perspective. And start by explaining the terms contained within the name FCS. So Familial Chylomicronaemia Syndrome. Familial, as you might guess, implies that it's a genetic condition. And a genetic condition means a condition where there's been a change in the DNA, the gene template, that is the template for making all the proteins in our body. And the particular gene change in FCS is a gene change that affects the activity of a protein called lipoprotein lipase. And lipoprotein lipase is responsible for breaking down fat. The consequence of that is chylomicronemia, the second word in the syndrome's name. So chylomicronemia is the buildup of fat, or specific fats called chylomicrons, in the blood. So you can see there in that middle picture, the blood sample taken from someone with FCS has this pinky, milky appearance. Compare that with a sample taken from someone without FCS that looks more like the colour that you'd normally associate with blood. And as a result of the build-up of the fats called chylomicrons in the blood, you get a collection of symptoms or a syndrome. So we've got expert patients here, so I'm not going to talk too much more about the syndrome, but move on a little bit more to how FCS and the diet are so important. So you can see that the fat in the diet, that's a very extreme example of a traditional plate of British fish and chips. A patient with FCS will never, ever be able to tolerate a plate of fish and chips. They will end up in hospital very unwell with pancreatitis, but I put it there as an example. So fat in the diet is absorbed into the circulation and packaged into these things, chylomicrons. Chylomicrons are then broken down into cholesterol and free fatty acids. And free fatty acids are an important source of energy. In order for chylomicrons to be broken down into cholesterol and free fatty acids, they require this protein or enzyme called lipoprotein lipase, the one that's affected by the gene change causing FCS. The result of that is that FCS isn't fully active, or may not even be active at all. Or sometimes it's not the DNA that is for lipoprotein lipase that's affected. It's the DNA for one of the molecules that lipoprotein lipase needs to be fully activated. So those are those other words you can see at the bottom there: GP1, HPV1, ApoA5, LMF1, and ApoC2. So sometimes it may be a problem with the DNA for one of those proteins. Either way, the overall result is that lipoprotein lipase isn't fully active, and therefore chylomicrons can't be broken down into cholesterol and free fatty acids, and instead they build up in the blood. So when chylomicrons build up in the blood, they can have a whole range of symptoms, and which are part of the syndrome, and you'll hear more about that from Jane next, and you've already heard some of it from Jill already. However, as clinicians, the first thing we may notice is perhaps the patient comes to us with another problem, or a general problem that needs a blood test, and the blood's taken and we see this characteristic milky pink appearance in the blood. Or the blood's tested and the triglycerides are noticed to be very, very high when you measure them in the blood, or maybe just that pink appearance in the blood prompts the laboratory to then check the triglycerides, and they'll be very, very high. At the same time, if the cholesterol is checked, it's either normal or it may even be low, because chylomicrons are not being converted to cholesterol properly because of the condition. The other major way in which patients may first present into hospital is with inflammation of the pancreas, or pancreatitis, and this can make someone acutely and severely unwell, or it could make them less unwell, but just not right, and really severely impact on quality of life. It causes grumbling, abdominal pain, digestive problems, and possibly even diabetes, because the pancreas is responsible for making insulin. And sometimes it may show up to clinicians as eruptive xanthomata. So these are the spots you can see on this gentleman's hand and arm. They're little milky white spots with a red ring around them. And the milky whiteness is the cholesterol or triglycerides that build up in chylomicronaemia syndrome. These problems very often show up for the first time in childhood, but may not show up until adulthood. And the time of particular risk for women is during pregnancy, when cholesterol levels and triglycerides go up a lot, and they're more likely to get pancreatitis, even if they've been relatively well the rest of their lives. So pregnancy is a time when a lot of people may present for the first time to health professionals. It affects females equally to males, and people are usually under 40 when they first seek medical help, but that's not necessarily always the case, but vast majority are, and it can affect all ethnic groups. And my final slide is to really go back to the title of this webinar, the dietary fat intake maximum 20 grams a day, although as Jill has already told you, for some people that can be a lot less than 20 grams. And that means that fat is not then being converted into chylomicrons, because it's not there in the first place. And by reducing the chylomicrons, it's a relatively effective way of reducing the symptoms associated with FCS. So on that note, I want to thank you for inviting me to speak, and hand back to Jill to introduce our next speaker.
Thank you so much for that, Charlotte. That was really, really clear and helpful, and I think gives us all a really good basis to understand the actual mechanics of FCS. So thank you. So now we're going to move on to Jane, and Jane is a patient from the UK who's going to share her very particular story about mostly about pregnancy, actually, and experiences during pregnancy, because as Charlotte indicated, that can be a very particular time of difficulty for women as they have children. And so many women are actually put off of having children or advised against it by medical professionals. However, I have 3 children, and although it was difficult pregnancies, I wouldn't be without them. So I would hate that anyone would go without children. Anyway, Jane, sorry, over to you.
I agree totally.
Thank you for joining us.
Hi, I'm Jane. I live in West Yorkshire. I apologise if you struggle with my accent, it is quite thick, but here we go. So I found out I had FCS, Familial Chylomicronaemia Syndrome, when I was 12. My sister too has the condition, and she found out when she was 8. I just started high school, and except for sticking to a low-fat diet, there was no other treatment or advice given to us at the time. My mum was amazing and started to feed us a low-fat diet at home, but I was at an age where I had some freedom, and for the next 7 to 8 years, I rebelled and decided that having fat in my diet was not a problem and has no effects, except for my blood test being high, I was okay. Explaining to me as a 12-year-old that I was at risk of heart attacks and strokes in my 30s and 40s seemed like forever away. When I was 20, I was pregnant with my first child, and this started a chain of events that would change my life. Repeated abdominal pain and pancreatitis. I had no warning of this, and it wasn't until I was pregnant and in hospital I discovered and started to think about complying. In later years, I discovered some advice my paediatrician got via Great Ormond Street Hospital in London, that pregnancy could cause pancreatitis and raise triglycerides. It had been in my records all that time, but had never been mentioned to us. Even my mum agreed she'd not heard it. I did manage to have 3 children and had pancreatitis constantly during the first 2 pregnancies. I learned quickly and the hard way that I needed to comply with my diet and the under 20 grams of fat rule. I do try to keep lower, but find 20 grams is right for me. I now needed to know more, and with the help of my fantastic GP and the internet, I discovered that what I had was a rare genetic condition, and unless I started to look after myself, I could die. During my final pregnancy, I had to have plasmapheresis, a process to clean my blood of fat, given 3 times per week. It helped me maintain my pregnancy until 32 weeks. I was so weak by this stage. My daughter was delivered 8 weeks early. I feel really lucky that she is now a normal 21-year-old. After having 3 children, I developed chronic pancreatitis and diabetes, which have made things hard for me. I now fully comply to the diet for the sake of my health. This has stopped the constant admissions to hospital. My admissions to hospital were difficult. My local hospital could not really help, and because of this, I had times when I was accused of having a drug problem when I arrived in the emergency department. As I was in so much pain, I was begging for morphine. I feel like I spent hours waiting for painkillers in the emergency room. Pancreatitis is so painful. I have had 2 stays in intensive care, also associated with FCS. I'm sure on a couple of occasions, doctors thought I was making it up. I was once admitted to a local hospital where the doctor went away and looked it up and came back and said, "Oh yes, I believe you now." Since meeting Jill and being part of the group Action FCS, I feel empowered, and I now feel like there is a voice for people who are newly diagnosed. I have an amazing consultant who understands the difficulties we have living our lives. I have lost and gained friends over the years who do not understand just that one chocolate could make me seriously ill, or just that one alcoholic drink will harm me. I have found real friends who understand that it's every day and all the time. My sister is the closest person who can understand how difficult life can be. She has managed to take part in a trial and is now on volaransorans with great results. I am grateful every day that I have her to talk to about how FCS controls our lives. As I have stage 4 cancer, I am unable to access the volaransorans. The cancer has meant also that I have to have a low number of steroid tablets when having my chemotherapy due to the diabetes. Steroids help for sickness in the few days after chemotherapy, and it pushes my blood sugar up alarmingly when I take them. Also, having regular bloods, there is a need to use a special kit when testing the blood to filter any fat to read liver and thyroid function results essential prior to chemotherapy. When I look back at my life, I have been traumatised by FCS. It's hidden away to most people, but I can see it's always sat in the wings, just waiting to remind me it's there. And I hope that gives you an insight into what we go through on a day-to-day basis.
Thank you, Jane. That was really powerful, and we really appreciate you sharing your story with us. And there's many aspects about what you described there that I think are familiar to a lot of people, actually, especially the not being believed, the being told that it's you know, that it's that you're there for a different reason, or just kind of, you know, finding it very difficult to get the kind of adequate information, especially when you're pregnant, actually. So thank you very much for that. So moving on to our next speaker, we're now going to be moving over to Professor Rob Hegele. And Rob, you're going to be talking to us a little bit about the genetics of FCS to understand how it is we get it, and what that means for future generations, our future generations, so for our children. So thank you, and I'll hand over to you now.
Great. Well, thank you very, very much. It's my enormous honor to have been invited for this seminar, this webinar, and to speak to you. I'm now trying to locate my slides, and I really, I wanted to thank, I mean, the previous speakers, Jill and Jane, for a really moving story. So I have patients in my own practice with Familial Chylomicronaemia Syndrome, FCS, that, you know, have had, you know, I mean, everybody has their own story, and, you know, so thank you for sharing those details. I'm now going to try, oh, here we go. This looks like it's working now. So I was asked to speak in the next 7 minutes about the genetics. And so just to recap, and Charlotte gave an absolutely stellar, clear overview of the mechanics of FCS, but just to set up the genetic aspect. So again, here is plasma from a person without FCS. So you can see after the blood cells have been left to settle on the bottom, you have then the clear plasma component. And in a patient with FCS, this is what we see. So it's those chylomicrons. Normally, the chylomicrons are gone within 3 to 4 hours of eating. Because of the enzymes that normally we have to break them down. But of course, that key enzyme, LPL, lipoprotein lipase, is missing. And so the chylomicrons, which then we look at them under a microscope, this is what they look like, these little round particles that have lipid in the core and protein on the outside. And if then the levels are too high, you can then develop these skin rashes, these eruptive xanthomas, and then, in fact, doctors, we can look into the back of the eye, and we can see this pattern of milky plasma in the blood vessels in the eye, lipemia retinalis. Fortunately, does not affect vision, but it is a telltale sign also. And then this is a picture of the pancreas internally, and so this is by far the most imminent complication is damage to the pancreas, inflammation and pancreatitis. And the pain that you've heard Jill and Jane just describe is described as the worst pain that can be felt. So why are there so many chylomicrons? So why does that develop? Well, in medicine, we teach our medical students that when there is a surplus of anything, it's either oversupply, too much being made, or failure to remove, failure to clear. So in the case of chylomicronemia, where those chylomicrons persist and give that, for over a lifetime, that milky, creamy plasma, the problem is on the clearance side. So, there's a normal input of fat. The fat is packaged by the intestine into these microscopic chylomicron particles, but there is a clearance mechanism. And I've depicted it here, for graphic purposes. So this would be, then you can think of lipoprotein lipase, the enzyme, abbreviated as LPL. So this is the normal way. And as I said earlier, this is when the lipoprotein lipase is working normally in like 999,999 out of a million people, those chylomicrons are removed effectively within 3 to 4 hours of eating. And in the past, in fact, most patients with familial chylomicronemia syndrome, initially when the DNA then was looked at, was actually on this basis. And in fact, this was considered a synonym, lipoprotein lipase deficiency. And it was, in fact, but now we know through the Human Genome Project that just as your vacuum cleaner has accessories, the hose and then the filter, and then so there are also accessory proteins in the body, in the bloodstream, that help lipoprotein lipase to work. And so you can then develop the same problem. So you can have, say, a problem in the genetic code, which then causes the vacuum cleaner not to be made, and then these chylomicrons accumulate. So that's one way. But another way, and then here's the population of chylomicrons. But another way is that the gene or the protein, the lipoprotein lipase itself, is perfectly fine, and the problem lies in the genetic code that makes one of these accessories, the ApoA5 or ApoC2, or this is real alphabet soup. I'm trying to keep it not very technical, especially this one here, GPI-HBP1. Anyway, it turns out that these are, so still quantitatively, most patients with familial chylomicronemia syndrome, 80% will have a problem in lipoprotein lipase itself, in the gene. But then there are these 20% of other patients that have the issue in one of these other accessory proteins. But the result is the same, indistinguishable, this perfusion and that plasma and those symptoms that I showed you. So why would LPL stop working? Okay, so here's your LPL, designated as the vacuum cleaner in the blood that's cleaning those chylomicrons out after a meal. And so the problem is the vacuum cleaner has not been assembled correctly. So here is depicting the sort of a text message or a work order to assemble the vacuum cleaner, and then there's the instruction manual. So the instruction manual of how to build correctly the vacuum cleaner then sends out, if you even want now, I guess, an email rather than a work order, and then the vacuum cleaner gets assembled. Well, in the body, the instructions to make every protein that makes us human, that distinguishes, that's in the DNA, the genetic code, the genome. Okay. And then from the genome, the information that is there is transcribed into this if you could think of it, work order or email, which is RNA. Now you've heard about RNA person, and the most famous example being the vaccines for COVID. So it turns out now that the information is the same. The RNA is just like, as I said, a work order that then tells the cell, instructs the cell, just taking the page, the instructions to make the specific protein that is needed. So to find then a flaw in this information flow, we can either look at the protein, and this is one way 20, 30 years ago that in fact we used to look at the lipoprotein lipase protein itself, the activity. But in fact, the technology is now genomic technology is it's like a laser beam. It's much finer, much better, much more accurate actually than the biochemical technology. And in fact, nowadays, when we diagnose this condition, we look at the person's DNA, and the DNA can come from, the DNA is throughout every cell in the body. Every cell in the body knows how to make lipoprotein lipase. It's just, it depends then on the context of when the instructions go out to make it. So we can look for it in the saliva. We can look for it from blood that is, say, left over from a lipid profile. Then there's DNA in that leftover blood. My mother taught me never to throw anything away. So we look in the DNA and we can find the genetic code. And so then, so here is then a depiction of a strand of DNA. And there are 4 letters in the DNA alphabet. So I don't want to get too, technical, but really our modern methods, and you would have heard of things like next generation sequencing or 23andMe or genotyping or genetic analysis. So it's able to read the DNA. So as long as we can read about the DNA for the instructions for lipoprotein lipase, we can with 100% certainty infer or what is going on, what that is like the flaw in how the protein is working. So that's why now we majority of the time the diagnosis is made at the genetic level. So this is an example then. So here at the one position of this, say this sequence, which let's imagine is encoding, making lipoprotein lipase. So there is a misprint in the instruction manual. And the body has very little tolerance for misprints. It's just like the way your computer, when you're entering a web address and you make a misprint in the web address, there's very little tolerance for that. Or if you're entering in your GPS and you make a misprint in the GPS for your vehicle, that there's very little tolerance for a misprint. So the same thing here. And then this is where the problem then arises for this condition of familial chylomicronemia syndrome. So the other thing to know about it is that we have 2 copies of every gene in our body, one from our mother, one from our father. And so this variant, we used to use the word mutation, but now we don't say mutations anymore or mutants. We call them DNA variants or pathogenic variants. So here, both copies, the copy inherited from mother and inherited from father, so both alleles, the medical term for that is biallelic. And so really for this condition to be expressed, it's a very unusual circumstance where both alleles for the gene have one of these misprints in it, and therefore the body, there's no valid instruction for how to make the vacuum cleaner, and the body cannot creatively problem solve. It's stuck for your life with. And so this can then be the identical copy, the identical variant on both copies, or a different variant on each copy, or can even be different variants in 2 different genes, mix and match. We've seen that before. So here, this would show, for example, the parents. So all the parents, so we say, like, what about the carriers of this condition? So by definition, the carriers have one copy that has a misprint, but then the other copy is fine. And for an enzyme like lipoprotein lipase, 50% of the function, that's often plenty. If you're like eating a normal fat diet and you're not stressing it with, kind of environmental factors, 50% enzyme activity is plenty. But then the problem is that when then two of the carriers just by chance meet, fall in love, have children. So and this is then going back to sort of high school biology. One quarter of the children, if the variant allele is indicated in the lowercase r here, 1/4 of the children, just through the laws of Gregor Mendel, will have a chance of getting both copies. 50% of the children actually will have one copy, and then 25% of the children will get both healthy copies or normal copies from the carrier parents. So it's 1/4 of children of two carriers then run the risk of developing this condition. So we've looked at it, and I alluded to this before. So here in this study, this was a study of the drug volanesorsen, an anti-RNA drug. Remember, I said that the information is also stored in the RNA. So this is one therapeutic approach then, is we can target not the DNA, we don't mess with the genome, but we can target the RNA, which then has the information. And Dr. Catapano will talk about that. But basically, so the approach study was FCS patients treated with volanesorsen. But 80% are variants in LPL, so LPL deficiency. But then the rest of them here shown, this is then where the variants are found in the rest of the patients. So about 20% have others. So there's other minor genes, ApoA5 and so on. So they contribute, and they are just as severe clinically. But it's a sort. So you have to have a method that would find the variation in all of these. And so that's for the lab to worry about how to find those. Okay, so what about the carriers? So Jill asked me about this. So the carriers, parents by definition are carriers. They have one copy. Siblings also, so for FCS patients, those of you with FCS, so 50% of your siblings will have one copy, but then they'll have one healthy copy. And then all of your children, if you have a partner, then presumably both copies of the LPL gene are fine, but you have only variants to give, all of your children will be carriers. So, but it's not so bad. It's a partial deficiency. So if you think about your parents lived their whole life as carriers, and so what we have found now, and my master's student did this project to say, okay, what is the phenotype of a carrier? So we find that 30% of the time, in fact, the lipids are totally normal. The triglycerides are fine. 60% of the time, they're just kind of mildly elevated, but nowhere in the near where that would cause chylomicronemia or pancreatitis or that milky plasma, which is maybe like a 1.5-fold increase in triglycerides. However, interestingly, of the carriers, the same genotype, about 10% of them are at risk where at some point they also might develop a severe hypertriglyceridemia. So the phenotype is quite variable in the carriers. But then who are these then that have one copy of the allele but then develop the severe triglyceride elevation? Tending to be male, over the age of 40, overweight, poor diet, diabetes, alcohol. So there's all these secondary factors. So then that partial deficiency becomes amplified in that situation. So here's my summary. I apologize. I know I've gone a little bit long, but this is my problem. This is not a trait of Canadians. This is just my problem. So but this is my last slide. So the familial chylomicronemia syndrome, there are two copies of a pathogenic allele, the so-called biallelic disorder. There are 5 genes. The main one is lipoprotein lipase. The population prevalence, we believe, we don't know exactly, but it's rare. It's in the range of 1 in 100,000. In some populations, it may even be 1 in a million. Typically, as you heard from Jill and Jane, it depends in infancy or, misprint there, or childhood. And then interestingly, by the time we still find adults, so if we still find in my clinic, some patients that have made it through into adulthood and then are diagnosed as having familial chylomicronemia syndrome at an older age, over the age of 18. But it's only 1 to 5% of adults with severely elevated triglyceride. Anyway, I apologize for going over time. Thank you for your attention.
Thank you so much for that, Rob. It was really clear and quite understandable. So I hope that everybody was able to understand how the condition is, how we guess it, and what can happen to our children. And I'd not heard about the how it affects the carrier, so that's kind of good information for me, actually, and allays some fears, I have to say. So now we'll move on to our last speaker, and so I'd love to welcome Professor Alberico Catapano. I do apologise, I was practicing that. And I'd like to say that you know, for most of my life, in fact almost all of my life, there's been absolutely no medication on the horizon, nothing at all. It's been a complete blank, and so medical appointments were very much going along, showing, you know, talking about how much fat there was in the how much triglycerides were in the blood, and then going away again, really. But in the last number of years, there's been a big interest in the condition, and a lot of different medications at different stages and available in different parts of the countries. So Alberico, you're going to tell us more about that. So thank you, and I hand over to you. Thank you.
I promise I'll try to keep shorter in order to gain a bit of time. However, I wish to make 4 points. The first point is there is hope there, as you mentioned, Jill. I mean, things have changed, and the impetus in research has been such that we now have a way of testing new drugs, detecting new pathways, understanding the mechanisms that Rob elucidated that bring a very high triglyceride and familial chylomicronaemia syndrome in a way that we can design the drug properly. And there is a sort of speedy track to develop those drugs that has to do with what Rob said, interfering with the RNA. To date, actually, we do have a drug that interferes directly with apolipoprotein C3. I'm not going to discuss the mechanisms. Rob made the name, which is volanesorsen. But what is important here is that this is an ASO, a short interfering RNA, that works in the nuclei and stops the production of ApoC3. You can have spectacular reduction of triglyceride up to 70%. Yet the message is that's available, can be prescribed, obviously is expensive because it is a drug for a rare disease, and FCS is a rare disease and is not available in any country because of the cost. This is an important thing. The second important thing is you as a patient organization have to realize how important is your voice in supporting research, because this is what has brought to you research. The research, even from different fields, came also to your area, and the interfering with RNA is an effective way of taking care of your condition. Having said that, diet remains cornerstone. You are not allowed anyhow, even with this type of drug, to exceed, in fact, assumption, because you will revert the benefit that you have with the drug. That's very important to say. But that will improve the relapses. You will have fewer pancreatitis, if any. Having said that, it is also important to remember that drugs can be improved. Volanesorsen is a small interfering RNA. New technologies are with it's an ASO. New technology with small interfering RNAs with a definite mechanism of action that allow for a longer interval between therapies, up to a month, 3 months, 6 months, are at the corner there. So that will be also available, are being developed and will work. There are different possible pharmacological targets that are being exploited. Not everything works, but you know, That's why you have research, and that's why you need to support research with your voice, which has to be loud. In the future, well, Rob say we don't want to mess with the genes, with the DNA. There has been an attempt there for a genetic therapy some time ago that was not really viable, was an heroic therapy, if you will. But there are new perspectives there that I think we should discuss in the future. That is, pharmacology has always been to decrease the protein, decrease something. Now we have new approaches that are linked to the CRISPR-Cas activities, which can increase also the expression of some genes if we want to have them, especially for the ones that we are interested in. And second, we can introduce specific changes and modify the gene accurately with this therapy. Obviously, this has to come, but please have a look into that, because there is a future there. And there is hope for even better treatment of the ones we have available. And I sincerely hope that will help as many patients as possible. Your condition is under the nose, certainly. And I think many of the people that are experiencing acute pancreatitis, there is an estimation that about 5% of them may be affected with the FCS, but they get unnoticed because they go to the surgery, they go to the other departments who are not aware of the condition. And that's also a very important thing to do. So that's what I wanted to say. I tried to be as short as possible, but I think I conveyed to you the messages I want to.
Alberico, thank you very much for that. So there is hope on the horizon, some interesting developments in new and innovative fields. So many things to think about in terms of how that might affect patients and the impact it will have on us. But certainly a very different kind of horizon to the one that faced me when I was a child. So we've got lots of hope for future generations with the condition that ultimately we get the kind of the gold star, which is a cure. I think all of us with the condition would like to be able to go out and eat as we pleased, but sadly that's not the case. But any help is welcome, and certainly minimizing symptoms is has a huge impact on us all. So just we're at the end. So that's the end of this. Has all been really, really interesting and inspiring. And before we finish, we'll have some time for questions in a minute, but we'd just like to remind you about the upcoming Rare Disease Day on the last day of February, 28th of February. And it's that date was chosen because obviously it's actually the 29th, but that only comes on a rare occasion every 4 years. This year it's on the 28th, and FH Europe and the network will be hosting several activities and represent our community in different events across February. There's more about it in the upcoming newsletter, so make sure you register for the heartbeats. We still have a few questions, and I'd like to ask our panelists about any interesting questions you've had in the Q&A. So we've got the question, do patients also need to restrict their calories to avoid conversion of carbohydrates to fat? Does anyone want to address that? So do patients need to try and eat less? I know certainly as a patient eating, that's obviously the more you eat, the more fat that you're taking in, because even if something's got low fat in it, if you eat enough of it,
there is not such a thing like a completely fat-free diet.
No, absolutely. But the question about kind of restricting calories, do we need to kind of be on a sort of, I guess, slimming diet really also?
I don't think that's going to make a huge difference, Rob. In our experience, that's not the point. Yeah. Okay, fine. So it's more about just managing the fat. And another question, actually, is there any evidence that PCSK9, which is associated with PCSK9 is associated PCSK9.
Which I know is an FH thing, but is that associated with FCS at all?
Not to my knowledge. I don't know you, Rob.
Yeah, no, they're totally different universes there. So that's LDL, and that's like a receptor problem. So Yeah, so there's no overlap. And in fact, when PCSK9 inhibitors on occasion have been given to patients with severe hypertriglyceridemia, there is no effect.
Okay, thank you. So we have a patient asking, I guess it's a patient, how frequently would you recommend testing fasting lipids during pregnancy for those with FCS?
I was having daily tests at one stage when I was in hospital. The hospital were feeding me food that we was agreeing that I could have, but I was having them daily, but at least 3 times a week when I was having the plasmapheresis. But it suddenly just jumps, and it can just jump overnight.
But I think you need to bear in mind that there is not such thing like fasting lipids in FCS, because they are an accumulation of what has been absorbed. So that's the point.
Okay. So it's interesting, actually, because we're always told to have fasting blood tests, but
Yes.
yeah.
That doesn't make much of a difference.
Well,
Yeah.
this is what I've heard lately, actually, which actually makes it much easier, because fasting blood tests can be quite difficult to manage in terms of getting somewhere. Yeah.
On the other hand, if a patient has properly been fasting, if a patient has fasted for 12 or 14 hours, and if there are chylomicrons present, then that's a telltale sign that there is, a major metabolic problem going on.
Okay.
But that's important more probably for diagnosis rather than for ongoing monitoring.
That's interesting. Thank you. And here we have a question for the medical professionals. Problem on presentation with this disease, usually to surgeons, and problem is pancreatitis often itself will cause increased triglycerides with milky plasma. Patients are often inadequately treated, since, as Jane outlined, surgeons may assume the problem may be pancreatitis caused by gallstones or alcohol. How do we get education for surgeons, especially when pregnancy is part of the presentation?
If I may, Rob, I'll start. We just started collaboration with people with gastrointestinal surgeons that take care also of pancreatitis. There are special units in Italy, and we are working with them. As I said before, they estimate about 5% of the patients they see with acute pancreatitis are FCS, but they don't know what to do, and they don't even care sometimes. They just, if you starve enough, the patient, the triglyceride will go down a bit, and they care about taking away the acute symptoms, and that's it. But they will present back sooner or later. So we have started collaboration. Education is the bottom line. You need to inform people, and we have started the collaboration. So every time they have a patient with high or exceedingly high triglycerides, they will send the patient to our attention at the lipid clinic, and we'll go through that.
Okay. And does anybody have any other perspective from Canada or the UK, Charlotte? Have you got any ideas about that?
Exactly the same. I mean, it wasn't even included in the UK guidelines for pancreatitis. So I think a big step would be to get it into their guidelines, the guidelines that they read rather than the guidelines that we might read about the condition.
Right. And so we better be looking out for when they're revised in a number of years, really, and bring it in there.
I mean, our surgeons in this hospital are good at letting us know, but it's very haphazard elsewhere.
Okay.
Same in North America.
Okay. So I think this probably needs to be our last question, because we're really coming to the end. Any utility of any anticoagulation meds to reduce thromboembolic risk in FCS patients? So this is for the medical professionals again.
If anything, they have thrombocytopenia. However, Rob.
Yeah, so I think no. I would say no in general. Although interestingly, heparin was used to diagnose the lipoprotein
Condition,
biochemically, and so there have been observations that heparin transiently liberates a small amount of functional lipoprotein lipase and can actually transiently improve, but it rebounds very quickly. So I would say the answer to that is no. Don't consider that there's any potential therapeutic value of anticoagulation by any mechanism for this.
Okay. Well, thank you all so very much. And I just wonder, I think we need to end now because we've actually come to the end. So, and what we would really love to know is how you found this session. And if you could just say that in the chat, that would be great. And any questions we haven't managed to come around to answer, we will actually discuss those. We'll send you the response separately. So I'd like to end this webinar by thanking all of our brilliant speakers for taking their time to present to us. I found it very informative and very enjoyable, actually. And I really, really thank everybody again. And thanks everyone for attending. And yes, we'll see you again sometime, I hope.
Certainly we will.
Thank you very much. Okay.
Thank you, Jill, and thank you, Jane.
Thank you, everybody. Bye now. Bye.
Okay. Bye.